This is part 4 of interview with an ambulatory care specialty pharmacist.
Yeah, so access to the EMR is great. I know that most specialty pharmacists don't. Places like Accredo and all the other specialty pharmacies, Carelon, CVS Specialty, Walgreens Specialty, they don't have access to the EMR. I don't know how they're able to do all the things that they need to do for their patients. And it's probably a lot of phone calls.
I was at a specialty pharmacy on our rotation. It was Walgreens. We did a lot of PAs for the PCSK9 inhibitors. And for Emgality, we had a lot. I think we were hooked up with the neurology clinic, so we had a lot of CGRP antags coming through. They would fax us the medical record. They would literally fax it. So it'd fax like 11 pages over of the medical record, and then we were the ones doing the PAs for the providers. So we would do it in CoverMyMeds, and sometimes it wouldn't even be in CoverMyMeds. It would be just faxed directly to the insurance company. Like, here's the medical record that I had to get from the provider. They were doing a lot. They were doing a lot at that specialty pharmacy. They were filling the prescriptions. They were mailing the prescriptions. And I'm like, they could handle it. It's at Community South, actually. They didn't have a whole lot of patients, but I was like, you're doing everything down here. It was crazy.
We do a lot of that for our patients as well.
That's a lot.
Whether it's for hepatology, we're doing all of the prior authorizations as well. I know for oncology and inflammatory, they're doing all of that as well. Yeah, neurology too. Yeah, we're doing all the prior authorizations, but we also have access to the EMR. So instead of all those additional 11 pages of faxes, we could just put the MRN number in
that pharmacy. They had folders, and they're labeled for patients, and I was like, what?
I mean, it's great that they have a system to help their patients, but not having direct access to the EMR. There's no room. That's a filing cabinet. You need a secretary for that.
Do you do appeals or anything?
Yeah.
Or a peer-to-peer?
We'll do appeals.
I don't think people know what that is.
Oh my gosh. I haven't gotten to do a peer-to-peer yet.
Okay.
I haven't been there long enough. But appeals is basically where the insurance will get back to us and say, no, we're not going to approve that. There's a reason.
Okay, good. I was like, you don't have to figure it out.
And it's really fun because sometimes the reason that they give us is in the original paperwork that we gave them, so we have to send it back to them.
And circle it?
Highlighted or circled. Yeah, I'd be like, right here where we circled it the first time, it's right there for you.
There's a diagnosis code in there.
And we promise to send it back to them. And because it's an appeal, it can take up to 2 to 4 weeks. Especially, it gets longer when it gets to second or third level. Usually by that time, for a lot of these specialty medications, we have access to alternate therapies or grants, what have you.
Payment assistance programs.
Grants, direct-to-patient programs where the manufacturer will just give it directly to the patient. As long as they're on these appeal programs and there's a chance of an approval, they'll go ahead and get that started so patient can start therapy and start feeling better. But yeah, insurance companies are a lot to navigate.
They are. And you guys can't receive samples, right? Because of that law, you can't, Pharmacies can't receive drug samples, but doctors' offices can, which is really kind of weird.
We can do emergency supplies and things like that if the insurances allow. A lot of what we have to do is within the scope of what the insurances will allow for payment. Insurances are the manufacturers, depending on what's what. Now we have access to different grants and programs to help reduce costs across the board. Copay cards are a huge mainstay of what we do as well.
Yeah, we do a lot of coupon cards too. You already know retail does that. I do them when I can. It's mostly just signing up for manufacturer coupons. I had a patient, his Eliquis was $900 for 3 months, and I signed him up for a coupon card. Boom, $30 for his 3-month supply. It really took maybe a minute or two.
The part is the pharmacy that you're working for gets the same amount regardless, because the manufacturer's paying that instead of the patient, so much better.
I can't even do payment assistance programs because of how long they take. I've seen them be done at Shalom Health and at that specialty Walgreens, but they require how much the patient is making, their income.
So security, background
citizenship,
checks.
Or there's a lot in
blood
there.
type,
There's so much.
Address.
I was like, I don't have access to a lot of this. Some of them actually don't meet the income requirements. Down at Community South, I feel like a lot of them on Medicare met the income requirements. They weren't making enough.
Luckily, with the Part D changes that happened in January 1st, we're getting a lot more people, less people that qualify, but the people that do qualify, we're actually able to make those grants go further because the grants don't have to spend as much money on one patient as they used to, because the maximum that they'd have to spend is $2,000. And then now we can spread it to well more patients, and we're able to treat a lot more patients with disease states that weren't previously able to be treated because they couldn't afford it.
That's cool.
So it is cool. It's just Medicare Part D. We need to expand it further.
What are your favorite disease states and favorite drugs and favorite stuff to manage.
Okay.
What's your wheelhouse?
I really love my hepatology patients because they are, first of all, a very wonderful journey to talk to on the phone. Because it's a disease state that you don't necessarily feel until you're at end-stage cirrhosis, you're a candidate for liver transplant.
Oh, wow.
So it's talking to them about a disease state that they don't necessarily feel. They might be partially symptomatic, which is probably why they went into the doctor's office to begin with. But I'm essentially giving them a drug that they will cure them. That they won't necessarily like for those 8 to 12 to 24 weeks.
What's the main side effects of drugs like that? Like is it Epclusa? Is your
Epclusa is the main one. We also have Mavorite. Those are the first two mainstays. Mavorite's actually a little bit more preferable because it's an 8-week course of treatment. So it's a little bit easier for us to coordinate with the patient and make sure that we have the follow-up because it's only one additional call for follow-up versus following them for 3 months. It's just 2 months of treatment. We also have YOUR.FAV.PHARMACIST, ribavirin, things like that. It really depends on their initial condition when they come in and if they've tried and failed treatment previously. But usually it's Epclusa or the generic. So YOUR.FAV.PHARMACIST, you say that 3 times fast. And then the Mavorite.
Does it make patients like nauseous?
Nausea is a given. So with Mavorite specifically, we tell them to take it with food. We even advise them take a little bit of food, take the 3 pills, and then finish their meal for that once a day. But nausea, vomiting is pretty standard with that medication. Of course, taking it with food really does help. We get some weird ones too, where both of them actually can cause a little bit of lucid dreaming.
Oh, wow.
Yeah, so they can have really weird dreams while they're on the medication.
That's kind of interesting. That's kind of cool.
Or excessive daytime sleepiness. So if it happens one way or the other, it might happen both ways. We're like, pick which one is less and take it in the morning if it's affecting your sleeping and take it in the night if it's affecting your daytime drowsiness.
That's interesting.
And we help them navigate that process too. I think the most interesting one is if they get hospitalized, they don't necessarily remember to take the medication with them to the hospital. And
it's not going to be in the hospital.
It's not going to be in the hospital. And then they're missing doses, and then we have to coordinate home medication administration and having someone bring it in. And that's not necessarily easy.
If you miss doses, do you extend the treatment?
We don't extend the treatment. What we'll do, depending on the guidelines, depending on how many doses they miss, we'll either get a blood work right then and there just to see how they're currently doing on therapy, or if they've missed less than a certain number, we'll just continue course of treatment and then just do our normal follow-up lab work after the fact. But we'll always check 12 weeks after they finished therapy to see if they cleared the virus with confirmation lab work.
That's cool.
Yeah.
Do you see a lot of resistance? Drug resistance?
There's a little bit in Hep C, not enough for it to be a problem with Epclusa or Mavorite for a mainstay if they're treatment naive. Not an issue to start therapy. The biggest things are if they're willing to start therapy, because some patients just aren't.